Welcome to the audiocast, The Need for Care Redesign to Reduce Costs and Improve Outcomes. My name is Michelle Bianco, and I'm the Vice President of Accelero Health Partners. Joining me is Jenna Desormier. Jenna is a Senior Director with Accelero. She has a Doctor of Physical Therapy and is a certified athletic trainer. The current healthcare industry is challenging us to evaluate the costs of care throughout the care continuum, but we know that reducing costs is just one side of the value equation. You must be able to reduce cost while improving the outcome for the patient. Jenna, today we would like to tap into your experience from working in several hospitals and hospital systems across the country and discuss how the process of care redesign can reduce the cost of care while improving the outcome for patients. Jenna, care redesign is a buzzword that is frequently used. Can you describe some of the key foundational elements of care redesign?
Absolutely. Care redesign in healthcare is really about 5 things: evidence-based practice, reducing risks and complications, increasing efficiency, improving function and outcomes, and decreasing cost. When we think about evidence-based practice, programs should really be using literature reviews, clinical practice guidelines, and recommendations from reputable professional organizations in order to create their order sets and pathways. A great example for joint replacement patients are those CAUTI prevention programs, aggressive mobility protocols, and preoperative optimization of the cardiac patient. When it comes to reducing risks and complications, again, programs need to utilize the most up-to-date evidence to drive clinical change. It also helps to hardwire these processes into the system, like assessing certain comorbid conditions and then instituting risk reduction programs to mitigate those risks. One such condition that we hear a lot about in regards to joint replacement is sleep apnea. It really is best practice to perform a preoperative screening for these patients and then institute a risk reduction for them preoperatively and then also while they're in the hospital. 2 elements of the care redesign process that really complement each other is the increasing efficiency piece and decreasing cost. We're really trying to apply the adage of working smarter, not harder. When programs create efficiency, they usually reduce cost because they are taking waste out of their system and reducing redundancies that aren't value added. One example is asking the lab facilities to send results directly to the PAT department as well as the surgeon, instead of having the preoperative nurse scramble to collect all of these documents the day before surgery. And also moving that chart review date up from the day before surgery to a week before in order to give everyone time to make changes if changes are necessary. Lastly, improving function and outcomes. This is really the ultimate goal of joint replacement. Programs should create consistent patient criteria, measure functional outcomes, ensure the patient is in the best condition prior to surgery by instituting a preoperative optimization program, and think long-term by instituting a physical therapy protocol that extends beyond the 4 walls of the hospital. Above all, the process needs to be deliberate and have staff and leadership buy-in. There has to be an intentional effort to reduce variability in standardized processes in order to care for the patient and achieve true care redesign.
Well, when you put it that way, Jenna, care redesign can make a big impact on transforming care for patients and the clinical practice for the care providers. When care is more predictable, they can have more time to focus on individualizing the care for the patients they're providing care for. How do you begin to tackle such a big task as care redesign? Do you start with the entire continuum or do you start small? How do you know where to begin?
That's a great question, Michelle. The first step really is making the case for it. And the greatest cost is in the hospital with the surgical event. So we typically start there by completing 1, a data review, and 2, a variability assessment. This will allow you to understand what is currently working well and what needs improvement with very concrete directions. Most medical professionals respond very well to data. And when we say data, we mean looking at the following data points to start: the average length of stay or the number of patients that are discharged on day 3 or day 2, discharge destination, pain management effectiveness, day of surgery physical therapy, readmission rate, revision rate, and even the CDM level data, so that you're looking at very specific data points. When we say look at variability, we're suggesting looking at variability by provider and by looking at it within the hospital and then also to best practice or evidence-based medicine. Things like pain management protocols, initiation of therapy or mobility, catheter usage, and CPM usage. The final step is creating an infrastructure. A program structure needs to include individuals who are dedicated to create and support change, from the C-suite down to the boots-on-the-ground frontline workers. It's usually a good idea to have a dyad approach, a physician or clinical champion and an administrative champion to work together to remove barriers and influence decision makers and other providers. The teams formed through the infrastructure then use the data and the variability information to establish priorities, either by impact or by ease of implementation.
Jenna, you have been very successful in facilitating hospitals through their variability assessment that you mentioned and establishing an infrastructure to define priorities to execute meaningful change. Can you please give an example of how you have seen care redesign reduce variability of care and improve costs?
Sure, I can actually think of two recent examples. At a recent engagement with the hospital system, we were charged with improving their program through updating their current order sets and pathways. During the data review and variability assessment, we saw significant differences in the blood transfusion rates in the providers that used tranexamic acid or TXA and those who didn't. Blood transfusions are costly and also increase the chance of complications for the patient. We also saw substantial variation in the pain medications used in the providers' multimodal pain protocols, with little to no difference in outcome between them. And this can lead to a pharmacy having to stock multiple medications with many doses. The program leaders were able to take this information, along with best practice information and the literature reviews, to the physician champions. After reviewing all of the information, the physicians came to an agreement that TXA should be part of the standardized approach to reducing the need for blood transfusions, and that a uniform approach to pain management could be used that minimized the use of multiple medications. This allowed the program to reduce their blood transfusion rate, which in turn reduced costs, as well as minimizing the number of medications the pharmacy had to stock.
Jenna, that was an outstanding example how keeping the patient at the center of the decision can lead to a reduction in cost while improving care. In this specific example, less blood transfusion and improved pain management, both critical to patient satisfaction. Can you give some examples of how preoperative processes and discharge planning can improve patient outcomes?
Absolutely. During the care redesign process at a hospital partner, we discovered that the program had issues with same-day case cancellations and complications. One initiative we undertook was to standardize the preoperative labs ordered prior to admission. That way, the preoperative nurse, surgeon, and anesthesiologist all had the information they needed to optimize the patient prior to surgery and make decisions about surgery in a timely manner. After implementation of this new order set, the hospital was able to reduce their same-day cancellations and had a 24% improvement in their complication rate in only 7 months. Similarly, at a hospital partner, we found that their joint patients were staying longer in the hospital and discharging to a skilled nursing facility or an inpatient rehab facility at a higher rate than our benchmark performers. We helped the program create a preoperative discharge planning process. This allowed the hospital to ensure that all of the patients were prepared to be discharged earlier and were able to be discharged home. This new process helped to create an 11% increase in the patients being able to be discharged home and increased the number of patients being able to be discharged on day 2 from 21% to 48%, more than doubling their baseline number.
Those are meaningful results, Jenna, not only to care practice and the patient outcome, but they also have the ability to demonstrate financial savings to the hospital. Everyone wins. What have you seen be the best practice to ensure this type of improvement is able to be sustained?
Well, there really needs to be a defined plan for the program and for the teams to provide guidance. There needs to be clearly defined leaders, and those leaders need to be supportive of the team members and be able to lead the team through tough times. There needs to be regular access to accurate data. Our hospital partners upload their data to us on a monthly basis and have access to that data through our proprietary business intelligence tool called OrthoVal. This allows the teams to have up-to-date information so they can make timely decisions. The teams also need to meet regularly and have clearly defined goals and action items to accomplish. It's usually much easier to start a care redesign process than maintain it. Just like the saying goes, it's easier to get an A than keep an A. The real work is done when changes are implemented, and the team needs to monitor usage and results so so they can make additional changes or tweaks to the process as needed. It's also the team's job to congratulate staff when goals are met and change is made. We always need to remember that change won't happen overnight, and we need to celebrate the small wins in order to keep interest and buy-in during the process.
Jenna, thank you so much for sharing your insight on Care Redesign today. Establishing an infrastructure, providing the team with meaningful data through a variability analysis by provider at a detailed level, and ensuring metrics are in place to benchmark your performance against will position your program for success in achieving and sustaining improved outcomes and reduced cost. This concludes today's discussion on the need for Care Redesign to reduce costs and improve outcomes. If you have any additional questions regarding this topic or others, please reach out to your local Zimmer sales team member and they can facilitate a discussion with Jenna or another member of the Accelero team. You can also reach out to us on our website at www.accelerohealth.com and then go to the Contact Us section. Thank you for your interest in Accelero Health Partners.